Hello. Today we've got a student presentation that I'd like to present. Well, she will be presenting. I'm just giving the introduction. Every now and then in this channel, I'm going to have some of my students put up presentations. I'll introduce them and then they will go on to talk you through their slides. This is double pronged. One is it encourages my students to share their work with a wider audience, but also it allows you to know what work my team is doing. And also sometimes it helps to kind of conceptualize topics that they may want to explore and have your feedback on this public and more open platform. So today we'll be talking about an MPhil dissertation. This was done by Shweta Chawak, who was registered with IIT Hyderabad, and I ended up being her supervisor after the first year, between years of 2013 and 2015. So she recently just graduated, and I'm very, very proud to say that she got an award for the highest CGPA. So the MPhil program constitutes of 1 year of taught work and then 1 year of research work. So after the first year of taught work, and I was away part of that year because I was away on maternity leave actually, she was anyway part of the taught program. And then in the second year, we put together a research design and protocol and received ethics approval for this study over the summer. And then she went off to do her qualitative research work in the first leg, where she did data collection and analysis and looked at whether some of the themes that emerged from the qualitative and the study could be fed back into the quantitative study. And while we had foresawn that we might have to add X number of variables, it was encouraging to know that we were not too far away from our research plan as such. Anyway, so then towards the end of 2014, she'd gone off to Bombay again to do her quantitative study, data collection and analyses. And then we went on to, in early 2015, we went on to writing up her dissertation. Now, we would have ideally have liked to do a qualitative study, a quantitative study, and another qualitative study that would have revisited some of the concepts that may have emerged from both the studies. But unfortunately, due to time constraints, because she had to submit her thesis by early April and defend it over the summer, we didn't have much time to really dig into some of the unusual findings, which I'm going to leave her to talk to you guys about in the rest of the slides. But that said, her thesis, her dissertation really was talking about topics that were never talked about before in psycho-oncology in India. And she found some really interesting findings, and she's now registered to do a PhD, and I'm hoping that she would want to unpack these a little bit more, closely. So yeah, that's it really, an introduction to Shweta Chawak, and I will pass on the rest of this presentation to her.
Hello all, I am Shweta Chawak and today's topic is on cancer communication titled Are You Satisfied with Your Care? A Mixed Method Study to Understand Patient Satisfaction with Cancer Communication. This study was conducted under the guidance of Dr. Mahati Chittam. When an individual is diagnosed with cancer, they are found to go through various psychological and emotional upheaval. They have to take in a lot of information related to their illness as well as their treatment. Hence, patients are found to seek information related to their treatment and also engage in problem-solving behavior. Studies have shown that when an individual is carefully explained about their diagnostic information, there is an increase in the patient's involvement in the treatment process. This leads us to understand the importance of cancer communication. So before we look at cancer communication, it is important to understand the relationship between the patient and the physician. This relationship is found to be a very complex one, where there is an interaction between two non-equal individuals, where one is seen as an expert, whereas other is seen as a follower. There are various research also shown that patient satisfaction with communication has a positive influence on patient health outcomes like psychological well-being, quality of life, adherence, and recall of information. Various research in patient-physician relationship has tried to look at the patient's preference in the physician's way of communication. Studies have shown that patients' personal characteristics like empathetic tone, affective behavior, and the interest they show in the patient's consultation has found to have a positive influence on the patient, and patient has felt to be more satisfied during the consultation. Unpleasant behavior like disinterest during the consultation has found to have a negative impact. Along with the personal characteristics, locus of control has also found to influence the patient's preference in communication. A study done by Hashimoto and Fukuhara has seen that individuals with external locus of control are more likely to seek emotional support from their physicians, and also individuals with internal locus of control look for more verbal support from their physician. Along with the personal characteristics, race and ethnicity has also found to influence patient-physician communication, where it is not only it not only influences patients, it also influences the physician. It is seen that patients prefer communicating with physicians who belong to similar cultural background, and physicians' confidence is also increases. It also increases when the patient belongs to the similar culture. So till now we looked at different studies done in West and Asia. In India, most of the studies have looked at understanding illness disclosure and quality of health care. There are some studies which has looked at supportive therapy and how that influences quality of life. There are studies which has also looked at how caregivers play an important role in patients' cancer experience. One of the interesting study has looked at patients' satisfaction with their consultation and how that influences the perception of information and in turn influences the compliance to treatment. Although the study was done on epileptic patients. Hence, till now we saw that past research reflects the importance of patient-physician relationship and how that influences the patient outcome. And although there are no studies which looked at medical consultation as a reference point in understanding the patient-physician relationship. Hence, the aim of this study was to conduct a mixed method study, qualitative followed by quantitative, to explore the patient's experience of cancer and how it relates to their relationship with their treating physician, and also to examine the relationship between patient satisfaction with the medical consultation and psychological well-being. This study was conducted in Dr. Balabhai Nanavati Hospital, Mumbai, for a time duration of 6 months. The participants were patients undergoing cancer treatment, and for this study, ethics approval was obtained from Institute Ethics Committee, IIT Hyderabad, and also Ethics Committee of Dr. Balabhai Nanavati Hospital, Mumbai. The first study was the qualitative study, which looked at patients' experiences of their relationship with their treating physician. The aim of this study was to understand patient perception and expectations about their patient-physician relationship. Here, 26 cancer patients were interviewed with a mean age of 54 years. And most of the patients were head and neck cancer patients and were undergoing surgery and radiation. Patients who agreed to participate in this study were interviewed. A semi-structured interview was conducted in English, Hindi and Marathi, according to the patient's preference, and interview topics mainly focused on understanding the treatment process, their perception about their first consultation, perceptions related to patient-physician relationship, and their experience of cancer. The interviews were translated in English and transcribed. Pseudonyms were used to maintain confidentiality, and further analysis was carried out by using IPA, that is Interpretative Phenomenological Analysis. The IPA was conducted using the following steps. Firstly, the transcripts were read and reread looking for common trends. These trends these trends and themes were grouped into to formulate the subordinate themes, which was further clustered together to form the superordinate themes. The second investigator individually analyzed the transcripts, and comparison was made to gain accuracy. By the 15th interview, thematic saturation was achieved, where further 11 interviews were carried out on the basis of the themes generated by that time. The various subordinate themes were first, illness beliefs. It was seen that patients were found to have negative reaction initially. That is, they reported to be scared and feared. And fear was reported. Although a change in belief was seen in process, where patients reported the patients were more accepting towards their illness. And treatment perception, second subordinate theme was treatment perception. Again, similarly, first initially the patients reported to be scared, whereas a change in reaction was seen, where the patients were found to be more accepting towards their treatment. And the various patients' experiences about their treatment and also their fellow patients' experiences were found to influence these perception. The third theme was supportive care needs, where patients were found to have some assigned roles to their family and friends and also their physician. They sought family and friends for information related to their illness and treatment. They also sought family and friends for psychological, emotional, and logistic support. Whereas the next theme was patient-physician relationship, where mainly they saw physician as a treatment provider and who basically took decisions related to their treatment, whereas they saw themselves as a passive participant in the treatment process. And they also gave importance to patient-physician communication, where they said that the way the physician communicated did have an influence on how they looked at their treatment process. And lastly, locus of control, where most of the patients reported their illness to be more externally controlled, where the most of the causal attributions were made to factors, external factors like God, karma, or past life. The major findings of the qualitative study was found to be that initially patients reported more negative reactions towards their illness as well as their treatment, although over the time a change was seen. And most of the causal attributions were made to be external, like to factors like God, karma, or past life. And thirdly, treatment perceptions were found to be influenced by the knowledge they got about their treatment, and also about how accessible and available the treatment was. Treatment costs were also found to have an influence on the way they perceived their treatment. They were found to have a assigned role for their caregivers as well as their physicians. They looked for caregivers for psychological, emotional, and logistical and information needs, whereas role of the physician was seen to be more diagnostic and treatment related. Physicians were seen as authoritative and unapproachable, although this was found to have an influence on how the patients adhered to the treatment. Following the qualitative study, a quantitative study was conducted, which looked at patient satisfaction with medical consultation and psychological well-being. The aim of this study was to examine the association between patient satisfaction with consultation and psychological well-being. A questionnaire was administered on 196 cancer patients with a mean age of 55.85. Most of the patients were individuals having head and neck cancer and were undergoing chemotherapy, chemo, radiation, and surgery. The various measures that were included in the study was firstly medical satisfaction scale, which looked at the subscales were distress relief, communication comfort, rapport, and compliance intent. Illness perception of the patient. Thirdly, Functional assessment of cancer therapy that looked at the well-beings, physical, social, how the relationship they shared with the doctor, emotional well-being and functional well-being. Hospital anxiety and depression scale, which looked at two scores, that is anxiety and depression. Multidimensional health locus of control that looked at different subscales of doctor, internal, chance and other people. Lastly, God locus of health control. Further, statistical analysis was carried out using SPSS. Demographic information like age, gender, time since diagnosis and treatment were also included in the analysis. Pearson correlation was carried out to understand the association between the variables, and further separate multiple regression was carried out on the subscales of MISS and its significant correlates. The multiple regression was basically carried out to understand the way the variables influence the subscale of MISS. This is the correlation matrix that showed the correlation between the different variables, where all the demographic variables were also included. The major variables that were found to correlate was found to be the relationship with doctor was found to correlate with most of the MISS subscales, that is distress relief, communication comfort, compliance intent and rapport. It was also found to correlate with external locus of control. Anxiety was found to correlate with relief from distress and communication comfort. It was also found to have a negative correlation with functional well-being. Out of the different demographic variables entered, time since diagnosis was the only demographic variable which was found to correlate with relationship with the family. So further, multiple regression was carried out on the MISS subscale, that is distress relief, communication comfort, rapport and compliance intent. The R-squares indicate the variance that was seen of the predictor variable on the outcome variable, so which range from 0.21 to 0.32. Although the variance is found to be small, it has found to have a significant influence, as the F change was found to be significant at 0.001 level. Further, this table indicates the beta values of the separate multiple regression carried out on the outcome variables of subscale of MISS. Relationship with doctor was found to be the greater predictor of most of the subscales of MISS, that is distress relief, communication comfort and rapport. And doctor locus of control was found to be the greater predictor of compliance intent. The major findings that was seen in the quantitative study was found that patients' feeling of distress during the consultation was found to influence the way they perceive the relationship with their physician, and individuals reporting low levels of anxiety during consultation was likely to feel less distress during consultation, and individuals who felt that their routine was disrupted due to the illness was found to report high distress during the consultation. And also individuals who believed that the doctor controlled their illness were more likely to feel distress during their consultation. Patients' comfort as communication was influenced by the way they perceived the relationship with their physician, and also the emotional and functional well-being was found to have an influence on the comfort they shared with the physician. Individuals who reported lower anxiety during consultation was again found to feel more comfort in the communication process. Next, patient's rapport with the physician was found to be influenced by the relationship they shared with their physician, and also the belief that the illness was due to chance. The compliance to treatment was influenced by the comfort the patient shared with the physician, and also that the belief that the doctor controlled their illness. Rapport was found to have a negative effect on the compliance to treatment. So till now we saw the major findings that were seen in the qualitative and quantitative study. Now we would be looking at the major conclusions that was derived from these two findings. Major overall findings seen in both qualitative and quantitative study were physicians and caregivers were found to play a key role in shaping patients' illness and treatment perception. Patients' locus of control was found to influence the rapport and the comfort they shared with the physician. And also patients' perception about themselves and their physician restricted them from seeking psychological and emotional support. Along with the major findings, there were some findings that were found to be contradicting in the two studies. That is, that was reflected in one study, although was not seen in the other. One such finding was that in qualitative study, physicians were basically seen as a medical care provider. Although in the quantitative study, emphasis was made that the physicians were looked for psychological and emotional support. Uh, in qualitative study, most of the causal attributions was made to God and karma, although this was not reflected in the quantitative study. This could be because of the complex understanding of God and karma, and hence more deeper analysis needs to made to understand these concepts. The major limitations of this mixed method study was found that generalizability is not possible because the data is specific to hospital in Mumbai. In quantitative results, we saw that the variance revealed was not of large amount, and hence there could be various external variable playing role. We failed to take into account the physicians and caregivers viewpoint, and we did not have a follow-up with another qualitative study, which could have led us to gain more understanding about both the studies. The future directions of this study: in research can further look at understanding the caregivers and physicians perspective and gain a more comprehensive understanding about the patient physician communication, and also gain insight related to the patient's preference in cancer communication. Further, clinical practice, physicians can use these findings to enhance their communication skills like empathy, rapport building, and also as majorly it was seen that patients wanted more information related to their illness and treatment. Hence, physicians can provide the same to the patients. And with this, I would like to conclude my study. Thank you.